Good morning, everybody, or afternoon, depending on where you're calling from. Welcome to part 2 of our Data for Advocacy webinar series. Data is a discussion. Really excited today to start what's going to be what I expect to be a very exciting series of presentations and hopefully lively discussion following. We have 3 presenters and 1 moderator who are joining us today. Megan Christofeld, Angela Mutunga, and Priya Emmert are our presenters, and our moderator is Rosemary Muganda. I'm going to start off with a quick bio to introduce you to all of them, and then I will pass it off to Rosemary to take it from there. So Megan Christofeld is a technical advisor for family planning at Jhpiego with over a decade of global health experience. She supports Jhpiego's global family planning portfolio, particularly in the areas of program design, advocacy, and innovation. Since 2013, she has supported contraceptive implant introduction and scale-up efforts in 10 countries, was the managing editor of the Contraceptive Implants Learning Resource Package, and a founding member of the Implant Removals Task Force. She's a certified facilitator in the Advanced Family Planning Strategic Advocacy Approach and holds an MPH in Women's and Reproductive Health from Johns Hopkins Bloomberg School of Public Health. Our next presenter is Angela Mutunga. Angela has just transitioned to the Advanced Family Planning Program this past June, where she served as the Africa Region Advisor. Beginning in July, Angela has transitioned to Jhpiego to serve as the Policy and Advocacy Director. And our last presenter, Priya Emmert, she served as the Senior Monitoring and Evaluation Specialist for Avenir Health in the Center for Monitoring and Evaluation, Analysis, and Advocacy. Her academic training and experience includes both domestic and international work in health policy, maternal and reproductive health. She began her global health work through the Michigan Population Fellowship Global Health Fellowship in Ethiopia. Prior to Avenir Health, she worked in the area of health policy for Futures Group and health logistics with John Snow and monitoring and evaluation with Crown Agents and the Gates Institute. In addition to her global health experience, Ms. Emmert has worked for Baltimore City Health Commissioner as a perinatal epidemiologist and research and social work with the emergency department at Johns Hopkins Hospital. And finally, Rosemary Muganda, our moderator for today. She is an advocate based in Kenya. She currently works at PATH as the Deputy Country Leader for Kenya and Interim Regional Advocacy Director for Africa. She joined PATH early in 2011 after serving as an Executive Director for the Center for the Study of Adolescence and the CEO of the Institute of Economic Affairs in Kenya. Her current role, Rosemary provides oversight for program activities, leads partnership building and networking, and is responsible for ensuring program quality with PATH Kenya program. She's also a member of PATH's Advocacy and Public Policy team, where she supports national and regional policy advocacy activities aimed at strengthening CSO participation and ensuring increased budgetary allocation for reproductive health, maternal, newborn, and child health. Rosemary has contributed directly to several policies and laws related to reproductive and maternal health in Kenya. Over the past 2 decades, she's been involved in health policy development and advocacy activities with a focus in RMNCAH, both in Kenya and in the region, as well as engagement at the global level on specific health-related issues. Rosemary serves on several committees, including the Advocacy and Accountability Working Group, where she's the co-chair, and the Global Financing Facility work stream of the Reproductive Health Supplies Coalition. She holds a bachelor's degree in social anthropology from the Institute of African Studies, University of Nairobi, postgraduate diploma in women's studies, and a master's in development studies from Flinders University in Australia. So we're excited to have all of these great presenters and facilitators. So Rosemary, I'm going to pass it off to you to take it from here.
Thank you very much, Greg. I want to thank everybody for joining today's webinar. As advocates, we need data to be able to conduct evidence-based advocacy work, and we need data that is reliable, is accurate, and that we can use in a form that we can use it. So that's one of the things that makes this webinar really, really important. This is the second in a 3-part series of webinars that the RHSC is organizing together with the System Strengthening and Advocacy Accountability Working Groups. The first one focused on which was titled "Tell Me What You Need, Data is a Discussion." This webinar served as an introduction to supply chain data for advocacy. The conversation focused on introducing the purpose of the webinar series along with the topic itself. In this second part, which is the one we are holding today, we're going to do a deep dive into East Africa and look at different examples of stockout data and how it was triangulated with advocacy efforts in 4 countries. We will also be looking at Jhpiego's work around consumables for LARCs, which will help to illuminate this topic more for us. We will end the discussion with around the efforts of advocates to unlock financial resources. We will also be looking at what is trending. We'll focus on what advocates are looking for in terms of the data and the challenges that exist in accessing data to influence financing structures. So I would welcome presenters who've already been introduced to you. So the floor is yours. Greg, is there an order in which they should go?
Yep, we're ready to go. So if you'd like to start, please go ahead.
Good afternoon. Can you hear me?
Yes, we sure can.
Yes,
Okay, good afternoon. My name is Priya Emart, and I'm presenting on behalf of Track 20 and Avenir Health on the data we have and the advocacy messages they may imply. Next slide. To start, the most important thing is agreement on the facts. The facts on stockouts can be very different to 2 people in the same country, depending on the source of data, the methods being measured, the level at which measurement occurs, when it is measured, and even the HR context of measurement. Here is a short clip on why agreement matters.
You have to believe in facts. Without facts, there's no basis for cooperation. If I say this is a podium and you say this is an elephant, it's going to be hard for us to cooperate.
Right, so he does it better than I can about agreement on facts from different people in the same country. Next slide. So I focus on data from East Africa, but the advocacy messages are the same in principle for different parts of Africa and even Asia. So what data do we have? Data that we have come from surveys, which offer national and subnational estimates on public and private facilities, and these include UNFPA supply surveys and SPA surveys, but do not include PMA surveys because they're not powered to provide reliable information at the national level. We also have LMIS data, which is routine data, and this provides continuous information as opposed to survey data, which gives you a point in time. But LMIS data may not include the private sector and is often constrained by reporting rates. If only a few good ones report, the stockout picture is different. Next slide. The next thing besides SOS is it's useful to know who reviews what stockout data and why. Stockout information provides different signals to those monitoring the supply chain versus those more interested in issues of access and coverage. This is usually a programmatic issue. Temporary blips seen in LMIS data may not be important if the overall supply chain is working well. And these temporary blips are usually not seen at the program level, which is with whom advocates are typically interacting. At the programmatic level, people are usually only seeing stockouts of a tracer product, usually the most popular product. The advocacy message here is to understand why LMIS and program people may have a very different sense of urgency about stockouts. Next slide. Along with the source of our information, reports on stockouts by method do matter. UNFPA supplies, which is the major source of all our stockouts data for FP 2020, reports different takes on stockouts method. They report stockouts of any method, which means that no single method is out of stock. And for most countries, this is usually a very high bar, and also not a particularly good way of reviewing stockouts. The more useful indicator is stockouts by method at the facility level, and this data is also provided by UNFPA supplies and by SPA. What we find in the few years of data that we have is that stockouts of popular methods are in decline. This is a good thing. But stockouts of some other methods that are less popular perhaps, or less used in a way, including female condoms and IUDs in this region. But also things like emergency contraception tend to be high. You should note that LMIS does not report on sterilization supplies availability. So when you're talking to someone on the LMIS side, they may not understand your concerns about stockouts. Next slide. So here are some examples from the region where injectable stockouts are approaching or have already approached industry benchmarks. That is, they're below 5% or close to that. And this is exciting news. Next slide. Implants, which are also becoming more common in the method mix. Expansion of implants is an important sort of strategy in East Africa. Implant stockouts seem to be declining in general. The major outlier here is Sudan. Rwanda is still way below 5%, so I don't think that's hugely important. Tanzania, we have a question, and of course it's limited 2016 data. Next slide. But a different picture for methods that depend on provider skill and incentives to provide emerges. Here we see for IUDs, female and male sterilization, levels of stockouts are quite high and unacceptably high. Look at Kenya and look at Malawi, for example, and Uganda. Rwanda is one of the few outliers here. And part of the reason may be, and here again, going to the issue of why there might be stockouts, countries tend to pay providers the same way for short-term and long-term methods, but long-term methods and long-acting methods require a higher level of effort. Paying them in the same way tends to disincentivize performance and may lead to rationing, sort of a preference to providing injectables, say, rather than an IUD. And so the advocacy message may be about pushing for case-based payment as opposed to capitated payment or input-based financing. Next slide. Here's an example from a country where one method is the tracer method, and that is the method that shows low levels of stockout. They're marked here, and you can look at this as data from Ethiopia from 2016 onwards, and you can see that levels of stockout have been falling steadily. And here, the advocacy message is that measurement matters. It's clearly because Ethiopia is monitoring injectable stockouts routinely, it appears to have had an impact on people because people are looking at the data, having some impact on how distribution inventory management is looked after, and leading to an important outcome where stockout levels have fallen. So the advocacy message here is push for more methods to be included in the methods that program people are monitoring. Next slide. Now here's an example when you mix and match. On your left-hand side of the graph, you have data from 2016, but this is from survey data. And on the right-hand side, you have data from LMIS data. And you notice that LMIS data in general trends lower than survey data. So when you're talking in country, it's important to know what data, what other people are looking at. If they're looking at your LMIS data, they might be fairly pleased with the level of low levels of stockouts and fairly shocked when you speak about high stockout rates. So it's important to look at that. But what you also notice in this picture is that levels of stockout seem to be declining per the LMIS data for injectables and implants. Next slide. Here's an example where we're just looking at only LMIS data. On the right-hand side, at the right-hand bottom slide, is looking at data from 2015, same 6 months, July 2015 to December 2015. Above that is July 2016 to December 2016. And on the left-hand side is data from LMIS from July 17 to December 2017. And what you can see here is that consistently, two methods have very high level of stockouts compared to the others, and these are ECs and female condoms. And I would suspect that the advocacy message here is that we want to think about the equity in the benefits package. So for subpopulations, for example, young women who might be using ECs more, for women who depend upon female condoms, improving system and provider willingness to track and provide these services, especially ECs, may be critically important. Next slide. This slide is essentially looking at 2 points in time for the same country, 6 months apart. And here you have stockouts, months of stock in December and in May, and they provide an entirely different picture. It's a reminder to advocates that seasonality matters, that we might not want to get too excited, but to check if there's a seasonal pattern. And if there's a seasonal pattern, it requires a different sort of advocacy intervention than when there is a consistent pattern in stockouts. Next slide. So besides methods of stockouts, levels of stockouts, sources of data, it's also useful to know at what level, in geographical level, we're measuring stockouts. Next slide. So this slide, uses LMIS data in the context of MCPR in Kenya. So you can see a distribution of counties along the S-curve, counties that have very slow growth in MCPR to counties that have reached high levels and are plateauing out, meaning that there's not much room for growth in these counties. And you can see that the majority of these counties are sitting on the growth slowing and plateauing. The point we're trying to make here is that if you have a picture of national level stockouts for Kenya, it is not easily interpretable in a highly decentralized and diverse subnational context. Second, it is possible that it may not be as relevant or important to focus on stockouts in the same way for these counties. So counties that have high stockouts but are also at the plateau level may have women who are more experienced users, and so they are more likely to seek out other sources when you have stockouts. So in terms of its impact on MCPR, the stockouts have less of an impact here potentially, but they would have potentially a strong impact in counties where acceleration is beginning or there's rapid acceleration. Next slide. So this is an example where a country has decided to combine information on training and stock availability. And here they're looking only at short-term methods. And you can see that there is a lot of variation in both in terms of time and also a little bit in terms of geography. Next slide. Here's an example of a country where they've also decided to look at long-acting methods where training does matter, and the distribution of facilities that have trained providers combined with whether they are stocked out. And here you can see that IUD levels are the ones where the advocates need to be focusing on, particularly rather than implants. Next slide. So the message really is for in terms of the data and advocacy is that improving visibility of stockouts first to program managers. So moving from just a tracer method to more methods, especially as countries' method mix becomes more diverse. Secondly, better alignment of understanding stockouts and provider availability. So there is a lot of economic sense not to think about stockouts if you don't have providers trained at those facilities. In a lot of places, governments, supply chains don't move stocks to facilities where there are no providers or maybe no intention of moving providers. For those who are concerned about subpopulations, the message is really that EC stockouts are very high and need to be addressed. Similarly, female condoms and sterilization. And lastly, a plug for maybe moving indicators into systems. So things like DHIS2, HMIS into GFF monitoring may be very important, for example, or in Kenya, for example, in the annual work plans for certain counties. That's it. Thank you.
Thank you very much, Priya. I'm going to take some due diligence in this time period right now to say that if you have any questions, please write them in the questions box. There's a comments box in the questions box. It'll be much easier for Rosemary to receive your questions in the questions box. And there's also a way to raise your hand. So there's a little hand icon that you can see on your platform, and if you click that button, you will be able to raise your hand and we can unmute you to ask your question in real time. Thank you. Great. So Megan, if you'd like to take it away.
Great. Thank you so much. And thank you, Priya, as well. So as noted, my name is Megan Christofield. I work here at Jhpiego. And first and foremost, I wanted to thank our teams in Kenya and Uganda, whose work is being represented here. So a huge shout out to them on that. And today what I'll be doing is sharing the story of how we use data and advocacy to overcome a persistent supply-related challenge in our family planning work. Next slide. So as Priya noted as well, in Sub-Saharan Africa, gains in implant use have exceeded combined gains for IUDs, pills, and injectables. They're accelerating growth in contraceptive prevalence worldwide, and as you can see at the middle of the slide, over the next 3 years, 18.2 million women are expected to receive contraceptive implants by choice across the FP 2020 focus countries. Next slide. When we look a little closer into the East African region, you'll see that here in Kenya, which is on the slide, contraceptive implants, which are in green or teal, kind of a teal green there, are seen growing in prevalence alongside overall MCPR growth. So for example, MCPR has grown impressively over the past few years to over 60% of married women. And implants make up over 25% of the method mix among that same population. Next slide. In Uganda, where the MCPR is a bit lower comparatively, still the proportion of users adopting contraceptive implants, again in that green teal, is rising. So you can begin to understand, the role that implants are playing in helping women and couples achieve their reproductive choice. Next slide. I think what's additionally so exciting about the increased excitement and desire for implant use is that really great gains have been achieved in improving the supply chain and resolving stockouts for family planning commodities at the same time. So the most recent PMA 2020 surveys in Kenya and Uganda show that in Kenya, 96% of public facilities and 98% of private facilities that offer implants had them in stock on the day of assessment. And in Uganda, it was nearly 93% of public facilities and 100% of private facilities that offer implants had them in stock on the day of assessment. So I think it really goes to show all of the great efforts that have come into play to meet, the reproductive needs of women and families. Next slide. Okay, but so what's the issue then? Well, implants themselves aren't the only supply necessary for their provision. Both the insertion and removal procedure require various instruments and consumables for provision, as illustrated on this slide. Lack of equipment and consumables can have profound consequences in our pursuit of ensuring rights and choice. Because without these materials, providers are forced to either forge onwards without the adequate supplies, thereby compromising the client's safety, or they have to delay or even deny the service. Next slide, please. So in 2016, under the Gates Foundation funded Best Practices in Implant Removal project, Jhpiego conducted an assessment that showed that no healthcare facilities that provided contraceptive implants actually had all of the necessary equipment to remove them. For example, you can see from this slide that in Uganda, which is represented in the darker blue, less than half of facilities had the antiseptic, blade, needle, and forceps that were necessary. And in neither country were gloves available at every facility. Next slide. In addition, we found that altogether, lack of equipment and unprocessed equipment were ultimately responsible for over half of the referrals taking place for implant removal, which altogether has presented us with a real challenge, which is that our capacity building efforts would only achieve, mediocre and short-term success if we couldn't address these other issues inhibiting healthcare workers' ability to provide critical family planning services, particularly this issue of consumable and processed equipment availability. Next slide, please. So what did we do? Well, we in Uganda convened an advocacy workshop where we engaged key in-country stakeholders to address this problem. We employed the Advanced Family Planning, or AFP SMART approach, to develop our advocacy objectives and strategy. At this workshop, participants identified an opportunity to integrate equipment and consumables into the GFF, the Global Financing Facility, procurement plan, for which money had already been set aside as a result of some previous advocacy efforts conducted by AFP and local partners. Next slide. So the specific objective that was developed at the workshop was to include implant insertion and removal equipment in the GFF RMNCAH equipment procurement plan by June 2018. To include the required implant equipment into the national procurement plan, specific members of the MOH Planning Committee and senior leadership who would inevitably sign off on the procurement plan were targeted with tailored advocacy messages. And notably, particularly for this webinar, those messages were supported with Jhpiego's project data that you have just seen on those previous slides. Then quantifications were conducted by supply chain experts to verify the quantities required. Please click. And so as a result, in February 2018, Uganda's National GFF Procurement Planning Committee adopted the addition of implant and IUD equipment and consumables into their procurement plan. And by May of this year, tenders had been issued for $2.2 million of equipment and supplies for LARC services, which is enough to cover every public facility in the country. Next slide. In Kenya, our team took a slightly different approach, but they used the project data shared earlier on consumable and instrument shortages and worked very closely with the Ministry of Health to have the equipment for implant insertion and removal listed in the National Equipment Catalog. And this was important because this helps dispel a widespread lack of knowledge on what instruments and equipment are necessary for the procedure. This is particularly notable for private facilities who are expected to purchase their own equipment and consumables and were largely unclear of what was required. Next slide, please. So these efforts demonstrate how data paired with strategic advocacy can be utilized for overcoming difficult challenges in service delivery, particularly supply-related challenges. While neither result from Kenya nor Uganda will completely resolve the issue, they certainly move us closer to closing the gap to ensuring that clients can be served on demand with quality services. Thank you.
Thank you very much, Megan. We'll pass it off to Angela to finish the last of the presentations.
Great. So this is Angela Mutunga, again working with Megani at Jhpiego, currently as introduced, serving as the Global Director of Policy and Advocacy at Jhpiego. I want to begin my presentation by appreciating the organizers of this webinar for inviting me as a panelist, and also appreciating the Advanced Family Planning AFP that Megan has already talked about, that worked on the piece that Megani has presented in collaboration with Jhpiego and the local partners there, as well as the AFP broader East African partners whose work inform my presentation. Next slide. I would like to begin by laying some quick background of the work of advocacy before transitioning to how we use data and our data needs to be able to continue to be impactful in advocating for reproductive health supplies needs and gaps. So the work that we do basically is very decision makers centered. And half that time, especially when it comes to increasing domestic resources at the country level, both nationally and subnationally, requires us to work to communicate, to unpack data for non-technical decision makers, users, whose responsibility is to pass and authority is to pass budgets and key decisions that affect the question of the day or the mandate of RHC, the reason as to why we are having this series of webinars. And just to state that these decision makers that we target are not just worried about our subject matter. Usually, or in most cases, they are worried about the whole universe, and very important for both data analysts and advocates to be tactical around how to present and how to analyze and present data in a way that asks simple, compelling, and convey a sense of urgency for decision makers to be able to act on the supply, reproductive health supplies issues as soon as we think they should. And so connecting with their universe to compel them to act requires a lot of repackaging of already packaged data so that we pick on that one particular issue that decision makers can act on now. In the next few minutes, I will be then walking you through the journey that advocates go through after data analysts present the type of data that increasingly sort of look like the image that are presented there. So our greatest worry is always to pick this one thing out of the great, well visualized data, which decision maker may have a lot of difficulties to understand, but unpack it in a way that some of the things that are presented in this data then are stated in words that are very locally contextualized, depending on whether the decision maker is technical or non-technical, whether they are national or subnational, and then making sure that we are unpacking and asking, presenting asks within their mandate of what they are supposed to do, irrespective of which level they work in. And so the first thing that I would like to point, especially to the data analyst, for you to understand some of the areas where we struggle a lot, is in ensuring that the data that we are using as advocates is locally owned and is just not national, but subnational as well, and is both quantitative and qualitative. When we get your data, we just don't use it as it is. We unpack it with a very subject line in mind so that we can produce profiles that are able to influence targeted decision makers to take very specific concrete actions at a certain given time within the space that we know very well that the decision maker is able to make it happen. So in short, we break it down as simple as possible so that we can be as spot on and we can communicate in a way, in a language that then helps us to get close not only to the art but full understanding of this decision maker so that they can be able then to appreciate and weigh in their action. How do we measure our impact at the end of the day? This is not the area that is our cup of tea. And so I begin to already highlight some of the areas where collaboration with data analysts continue to be very important as we go into the journey of ensuring data is utilized by decision makers for taking the type of decisions that then eventually save the lives that we want to save together. Next.
Hi, Angela.
Next.
Just to make sure we're on the right slide.
Yes.
Okay, great.
So can you keep clicking? Can you click this? Yeah. No, go back. Good. So again, as I just stated, looking at what I've just said is that in the puzzle of very many problems and worries of decision makers that are just beyond reproductive health supplies, we then unpack your data to ensure that the exact missing piece that have the highest potential to be acted on by decision maker is what we pay attention to. And so we have to labor to bring it home. And I would like you to appreciate that locally owned data increases the chances of decision maker to take action. You distance it so much from, for example, in Kenya, we do have counties, we do have national government, now we do have our neighbors, Uganda and Tanzania. If we start talking about data collected in Indonesia, then it starts to sound very foreign. So we try very much to ensure the data that we use can be identified by decision makers. And so it has to be, again, simple and very focused. Focus on local interest. It has to be compelling. We have to send a sense of accountability to decision makers and the sustainable environment in which their actions will contribute to, while bringing a very strong sense of collaboration with their key constituencies that they care very much about. Next. So I did say that my presentation is borrowed on the work that I keep clicking until all the, yeah, sorry, I shouldn't have done this. Okay, while you're there. So in very simple terms, regardless of the tons of data that we have, our simple, or rather the long journey of our work intends to take us to reaching the right decision maker with the right message at the right time. And so, sometimes when I listen to people talking and describing who advocates are, they say that advocates are these guys who just talk. I want to tell you that we just don't talk. We think a lot beyond just data analyst data to make sure that our message passes through, anatomy, physiology of messaging to ensure that at the end of the day, the facts are understood. They are not distorted, but they are not complicated, then to be appreciated, especially when it comes to how we communicate the problem and the value add that the decision maker is going to take. I do not know what is the most complicated procedure when it comes to things like surgery, as an example. I want to believe that if I was asked to open a brain of somebody, that is one of the most complicated procedures. I want to tell you that for advocates, it's not easy. It's equally complicated to be able to get all the data sets that analysts have around an issue and make sure that eventually we get a message to decision makers that is very right that is on time and on point, and pass it across in a way that then gives us the type of results that everyone is looking out for. Next. So just, the reason as to why I am emphasizing on how simple, clear, compelling a message is so that we understand decision makers, in terms of appreciating data, are not very much interested in very many slides and graphs, and they want something as simple as this particular image. And all of you, when you see this, you see Mercedes-Benz, others will see class, others will see. So we have to work on the background, in addition to having good quality data, to ask ourselves, decision maker A and B, in two different places that are supposed to act on, reproductive health supplies, issues at the same time. What is it that would help them to see the issue as clearly, as simply, as important, and identify with it and act as soon as we can? So keep clicking. I need to see the words, Greg. So basically the message here is that we have to break data down. And while I'm on this point, it is important that we continue innovating and inventing together with data analysts, so that we can get better at analyzing data and briefers that then are very geared towards decision makers as consumers of data to unlock, financial, policy, political barriers, whatever it is that we need, because they are worried, as I said, about very many things, and we need to get to their heart. We need to convince them as soon as we can, without compromising ourselves and the time that we have by complicating data. And so we spend a lot of time trying to take analyst data to be able to do this. Next. I will not focus a lot on unpacking these slides, but basically I wanted to showcase what the journey that we take the analyst data to, again, decompress it, reanalyze it in a way that sends the type of messages that I've been talking about. Looking at the heading here, for example, it's about targeting the decision makers in Kitui County, which is one of the 47 counties in Kenya, governor, the minister of health, the chief officer of health, and the top line decision makers, in a way that we help them to understand how family planning will save lives of their constituencies, and the end, how it will save their money. Remember, decision making is about what is in it for me, and woe unto you if then your asks, especially on domestic resource financing, is then getting to the political decision makers who want to do everything possible, not only to be visible, but also to make sure that they are voted back. And so we have to begin right, and we have to start tracing and unpacking data to be able to get here as quickly as possible. And so this is one of the most popular briefers that AFP Smart, in collaboration with the Impact Now modeling, have been utilizing your supply chain data to ensure that we get messages and then reanalyze them to be on spot as much as we can to increase domestic resources for supply, for reproductive health supplies. Next. The profiling continues. Next. So again, as I said, we think decision maker and what is in it for them. So it is not enough just to come up with a catchy title and talk a lot, but be able now to use data which is credible enough, which is very local, then to be able to showcase what exactly do we mean when we say you will save life and also save money. And that is what this type of briefers then eventually utilize the data that you present, that is there locally, to help advocates to pitch so that they win as fast as possible without missing. Next. And so whatever we do, then we have to end up with a call to action. And this particular slide, I would like you to take one very important fact away from it that we have to, advocates pay attention to, and that is progressive development. You realize that the data that analysts present, it gives recommendations that are worthy perhaps, planning and investing on in like a 10-year period. And so what we try to do is to scan the environment and go beyond this data to understand what's happening with this decision maker, so that we can push one or several asks at a time or in a year for us to increase our chance of eventually working towards eliminating the whole challenge. And so what this means is that sometimes, you have to think long term, but with a lot of immediacy and urgency. And what this means is that you are likely to have different regimes coming, and you have to be ready, to transition with them. When we started working in Kitui, we had this governor, and now we moved on to have Her Excellency Charity Gilu as the current governor of Kitui, and we've transitioned very well, and work continues. Next. Next, Greg. So as I conclude, over time, we've managed, go back, Greg. So basically, utilizing that approach, so we are managing to unlock not only in Kenya, but across the East African countries where AFP has been working, to have dedicated budget line items for family planning, and a lot of that, going into supplies, amongst other things. And so, for example, where the AFP program works in Kenya, which is about 16 counties now, out of the 47, you managed to unlock in the past 3 years over $2 million for family planning for different counties. And you can see, quite a number of related policy changes in the process, are coming up, and policy frameworks that then guide the long-term investments that I talked about. Next. So housing, preparing platforms that then are ready to consume data as soon as it is produced, while also bringing the data analysts on the table to work together with us. So advocates try to think comprehensively, and then establish or strengthen existing systems, or platforms to ensure that data consumers then are engaged, continuously, for us to be able to get where we are nationally at the county level. These are First Lady champions who are doing incredible work here. Council of Governors, Health Advisory Team, again, looking at data and what it means here for them to be able to understand why the asks that we are bringing on the table. And lastly, Greg, next. So what is trending? Global financing facility and universal health coverage. Colleagues, and particularly, as an advocate, I will end with an ask. We have not done a good job enough to utilize the data that we have to get on board with a global financing facility, because as Megan presented earlier, it is beginning to bear huge results. And I think collectively, together with the work stream, that has more data than we do, then we need to quickly get on board, because in Kenya, we were able to unlock 20 million. We were able to follow up again with intense advocacy to make sure that the allocation is translated into commodities, and now we are getting into tracking to know where the commodities are going, including now launching a second wave of advocacy to continue to increase into this port nationally. So what do we need? Next. We would like to partner right from the start. When we don't communicate, coordinate on time, then we lose out on time and decision makers transition or situations become worse. Let's do a better job at this. A lot of time, we don't get data. We are told data, this is very confidential. So if data is too confidential to be analyzed, to be just kept confidential, then we shoot ourselves in the foot as analysts, and then advocates fail to serve you and to consume data to increase chances of us winning together because of that lack of mistrust. You will help us to understand where we went wrong and what you want to see in us so that we can begin to have this data shared. Investing in local data and analysis expertise continues to be important. Country level data to include subnational disaggregation is so critical because it is now the subnational units that are increasingly seeming to be doing a better job of unblocking bottlenecks. And in short, I would say that if we partner, coordinate, and work together right from conceptualization of data collection, tools development to analysis, and then advocacy, will truly transform lives and win together. Last slide, I want to say, shukran, looking forward to more interactions.
Thank you, Angela, Priya, and Megani for the presentations. Given the time left, I'm not going to go to summarize the presentations because everybody was listening. Can we then just move very, very quickly to questions? I'll read out the one I have here. I hope you can all hear me. Yes. Okay.
Yes.
There's a question for Priya and others. And can we just restrict the responses to very, very brief comments? Priya and others, somebody wants to know, can you explain more about reasons for the high stockouts of VCs and what needs to be done to reduce this, and also whether adolescents are most affected by these stockouts?
Okay, this is Priya.
We continue to receive questions as Priya responds to that one. Yes, Priya, go ahead.
Very quickly, ECs, the main reasons for stockouts are one, that's cited is lack of demand. And the second one is failure by higher levels to supply. And the third one is failure to request. So by order of importance, it's demand, failure to supply, and failure to request. So the last two are about logistics. The first one, according to providers, is about demand.
Okay. Thank you, Priya. Do we have any other questions? Greg, you talked about a hand that could be raised. I am looking for that little hand on this screen. I cannot see it. So does anybody have a question?
So far, no hands have been raised. I would like to add that if people have a few more minutes, we're happy to keep the link open to continue to respond to questions if there are any. Please feel free to write your questions down. It looks like we just got another one, and feel free to raise your hand as well if you'd like to be unmuted.
And oh God, I cannot see the question.
Okay, so one question we have is from from Laura again. The question was adolescence.
Is the question on adolescence?
Here, Laura, what I'll do is I'll unmute you so you can ask your question directly. Please go ahead.
Thanks. I was just trying to ask if adolescents are the most affected by the EC stockouts, or what do we know about how adolescents are affected by different method stockouts?
So if we look at the DHS data, I mean, we can look at the by method use. and ECs, which sub age group is using ECs the most. I don't have that data right in front of me, but from what we hear at the country level is that, and again, I have not looked at the DHS data to compare, is that a lot of EC sales or consumption is happening through pharmacies and the private sector, and EC consumption is not showing up in the public sector. But the data that we have is that the public sector's, in terms of stockouts, has high levels of stockouts. So country level anecdotal information is that it's mainly adolescents.
Okay. Marta, you had a question. You can be unmuted so you can ask. Is Marta still on the webinar?
Hi, Marta, you've just been unmuted. Please go ahead. Marta, it looks like you're self-muted. If you'd like to unmute yourself, we've opened it up for you to speak.
Well, it seems Marta can't hear us, but Marta was basically asking if the data that I think Priya cited was from Sudan or South Sudan. You referred to.
I showed data from Sudan, but we do have data from South Sudan as well, which I did not show.
Okay. Sorry, Marta is unable. She can hear us, but she can't speak. But I think her question has been answered. Greg, do you want us to end it now, and then people can stay online and ask questions? We'll continue to respond to those.
That sounds great. We have a question from Ulatum Bosun, so I'll unmute him, but I would just like, before I unmute him, I would just like to thank everybody for joining. We can officially close this, but we'll keep it open to continue to respond to questions. So
thank you very much, Priya, Meghani, and Angela. This was fantastic. The presentations were fantastic, and I hope that we can continue to do more of these where advocates and data people collaborate for better outcomes. So thank you very much. So we'll stay online for those who are able, so we can respond to some of the questions. So thank you.
Yeah, hello.
Hi.
Hello.
Yeah, my question is, how do you get family planning commodities to hard-to-reach facilities?
Okay, Priya, who wants to take that one?
Well, that's a logistics question, really. It's but it really depends on how your supply chain is working, and whether they have systems set up where they have regional warehouses positioned in a way that are deliberately set up to resupply, that there's good data and good reporting from those facilities to understand consumption levels. And also access to transport. In some of the information that we have from surveys, we find that facilities report that having to rely on transport and not having access to transport, especially the hard-to-reach facilities, that this is a constraint. But in general, it's about the national supply chain setting up a system that is geared towards the frequency of resupplies and geared to making having enough of a buffer stock, especially for hard to reach facilities, so that they do not run out and do not have to wait for emergency resupply.
And this is Megan, and just to add to your question, I think it was Wilson, is that when it comes to equipment and consumables, I think we're finding that that actually data and advocacy become very critical to ensuring that these materials are available at the facility level, because even in our experience, facilities have been experiencing these shortages of consumables and equipment for quite some time, but we're finding there's a bit of a breakdown between facilities, and even the district or county or whichever subnational kind of office oversees the public facilities. And so sometimes it's just been a matter of saying, okay, what if we kind of quantify the problem and actually give you some data about, how short are we? I think everyone can appreciate that without gloves, a procedure is very compromised. And so instead of just saying, oh, we don't have gloves, if we can put some numbers and data behind it, it makes, and some good advocacy messaging, it makes a more compelling case. And so, I completely agree with Priya that it's a logistics issue, but I think when our experience for consumables and equipment is like really putting some data behind the problem is helping us to make that ask more clear.
And just to add that, at the country level, there are very many tiers that, decisions and data has to pass through to inform the national level on what to procure and then what to send down, depending on whether a country is operating push or a pull model. So delays, can occur because of different reasons. So depending on a country by country, reasons for stockouts or overstocking in certain areas and not others, and the system that takes supplies from one point to another is complicated, is very diverse, and what Megan has just talked about is that advocates on ground are trying to use data to get to the pockets where and geographies where we are having certain type of problems, to institute or to advocate for policies for example, local redistribution from a particular, one facility to another, or, advocating for better quantification and improving the overall logistics system to be put in place, at various places, including perhaps, setting up in countries different distribution systems for both public and private sector.
Do we still have any more questions or any more people still on the line? Greg?
So we have no more questions left, no more hands raised.
Yeah.
There are still left on the line, but I think that's it.
I think we've done a good job. So thank you, everyone. Thank you, Greg and Johnny, for organizing this, and the presenters, thank you for making the time. This was good, and we hope that we can do this again. Thank you very much.
Rosemary, you are a great moderator. Johnny and the team from the panelist bench, thank you very much.
Thank you. Have a good day to those whose day is just beginning, and then a good evening to the people who are going home now.
Thank you very much. Thank you, Greg, and of course to Ellen.
Greg.
Thank you.
Bye.
Bye.